Welcome to our webinar that we are doing on the executive order, talking about creating access to insulin and injectable epinephrine for our low-income patients. You all know me. I'm Felicity Homsted. I am the CEO here at FQHC 340B Compliance, and I am joined by my two fabulous colleagues who will introduce themselves. Logan, if you want to go first.
Hi, I'm Logan Yoho. I'm Director of Advocacy and Education here. I'm a pharmacist by trade.
And I'm Michael Gonzalez. I'm the CFO.
And also the founder of our company. So it is wonderful to have everybody here with us. And we know we don't do enough of these webinars. It's our goal to get more of them to you. So look out for the poll question at the very end, where we'll see what other types of content you want. But we know that this is such a hot issue that we wanted to make sure that we connected with you, that we answered questions in a live format. And so what we're going to do is we're going to start by just doing a little bit of an assessment to understand what you know so far, test your knowledge a little bit. And then from there, we're going to go through the executive order in detail, go through the terms and conditions in detail, what you need to know, hit frequently asked questions. And after that, we're going to have open Q&A. So if there are things that you are wanting to know about that we haven't touched on, we will address those as well. So we're going to jump right in. In the handout section, you will have all sorts of wonderful resources that you can download right there. They will not be available for download after the webinar ends, but if you have not gotten them, you can of course reach out to us and we will send them to you. Please also introduce yourself in the chat, and so say hi to everybody. So way to go, Brooke. Thanks for getting it started. And so we're just really happy to have everybody here with us to talk about what has been a little bit intimidating, a little bit challenging, and again, you've already met us, so we'll jump right in. Just a little bit of a timeline of what has happened. You all may feel like we're having deja vu because we are. We had the insulin and injectable epinephrine executive order back in 2020. And so at that time, the language was essentially identical to the language that we have this time in 2025. And we're just draw your attention to the fact that HHS did publish a rule previously addressing the implementation of the insulin and injectable epinephrine executive order. That was rescinded by the Biden administration, but we do draw your attention to it for one particular reason, in that the federal government did interpret that previous executive order. And so while there are some changes in how we've seen it implemented in the terms and conditions, particularly around the income level, what we do see are some really important tidbits in there that we'll highlight as we go through the presentation that were interpretations by the federal government that are reasonable for us to make as well. So jumping to the next slide. Oh, is this one? Okay, this is Logan.
We may have the order wrong, but we'll go with it. So we're going to start with our poll questions. So how well do you feel like you understand this executive order? Are you confident? Are you still learning? Or are you really at square one and need the help? We'll give it a few moments for everyone to answer and
polling the panel, right?
Yeah.
At this point, I think Logan and I have been eating, sleeping, and breathing this executive order. So that's why we're here. We're feeling pretty confident. Michael, how are you feeling?
I think I'm good with it. I feel like most of our health centers are already doing this. And so I don't see this being a huge additional burden, but definitely some loose ends that people want to tie down and make sure that they are compliant. I feel like most of our clients are doing this.
So I will say I'm very proud of you all to say we have 7% are confident, and so very well done, because we definitely are not getting that across the space in a large group in the still learning, and so that's right where you want to be and where we expect you, and a few who are at square one, and so you are at the exact right place. So
right, take it on this one.
All right, so true or false? This is where we are in the test session, okay? And we're not going to tell you the answers right now. So this is just for us to kind of assess what do we know, and so we will give you the answers at the end. Also, they'll be peppered through the presentation. So health centers are required to offer reduced pricing at all of your contract and entity-owned pharmacies. True or false? When it's pretty heavily weighted so far. So we're getting a lot with false, and so more saying false, and some coming in with true. And again, we'll give you the answer as we go through. Logan?
All right, so true or false again, the access to discounted 340B medications must be given to all low-income individuals who present at your pharmacies.
We got some early responders very confident in their answers. We'll give you all just a minute or two to respond. And so these are based on some of the most common questions that we are seeing. So we got about 2/3, or I guess a 75-25% split on most people coming in with false. Oh, it's going
This
to
one's getting closer.
Yeah. Woo. So this is a good question. And I believe this is our last one. True or false, the executive order requires FQHCs to provide 340B pricing on all diabetic medications. Ooh. This looks like we got some people who are already very well informed. Excellent. All right. So a little more of a split here. So 96% coming in with the answer false. I may have given away that one a little bit.
All right. So getting into the content, I think it's really important that we take a step back and we look at what the actual executive order said. So back on April 15th, President Trump, once again, as we said, it was a bit of a repeat from the 2020 Trump 1 administration. He put out the lowering drug prices by once again putting Americans first executive order. So important in this executive order was that it gave Secretary Kennedy 90 days to implement this executive order applicable and consistent with the law. So the executive order was to make insulin and injectable epinephrine available at or below the discounted price paid by the health center grantee or sub-grantee. So it's really important that we highlight that discounted price paid. We'll come back to that. We are allowed to add a minimal administration fee to that. And this applied to individuals with low income who also had one of three situations. They either have a high cost sharing requirement for these products, they have a high unmet deductible, or they have no healthcare insurance. All right. And Felicity.
Okay, so jumping in, and again, we are emphasizing the language that's in both the executive order and the terms and conditions, because one of the biggest challenges that we are seeing as we're working with health centers all across the country is that there is a lot of people reading things into it that are not written there. And so most important for us is that we know exactly what was written in that executive order in our terms and conditions, because that's what we are being held accountable to. And so while it may feel like we're harping on this a little bit, it's just, again, really important for you to know what do the terms actually say, so that you are being held accountable to those terms, and that you are over or underperforming as you look to implement them. So first of all, in the terms and conditions, we're expected to have established practices, right? And so that is us setting up our policies and procedures, making the insulin and injectable epinephrine available at or below the discounted price paid, right? So we have the two types of products that are a limited list of products, right? So to that question, is it all diabetic? No. And it's not even all types of epinephrine, right? It's injectable epinephrine. Making sure that you also note that it's the price that you paid. So in situations where you do not have access to a 340B discount, there's not an expectation for you to pass on pricing that you did not receive. Okay. It applies.
I would say one thing about that is when the original executive order was instituted in 2020, we had very few of these contract pharmacy restrictions. So the situation is much different now than it was in the original time.
Making sure too that if you have subrecipients involved in your FQHC, that you are also applying it at the subrecipient level. There's not a ton of health centers out there with subrecipients, but important that it's being applied in all areas of the health center, both the main recipient and your subrecipients. And then that you also have the opportunity to apply a minimal administration fee. We'll talk a little bit more about that in detail. And so that it goes for low-income individuals that have high cost sharing requirements, high unmet deductibles, or no healthcare insurance. So what was different this time in 2025 versus 2020 was that the secretary did a great job of defining what is low income, and they aligned it with our health center standard that we already use for low income, which was at or below that 200% of the federal poverty guidelines. So this aligns with what we have already been using when we calculate our income levels. And so that is really helpful for us. So what is really key here is not having to create a new standard, using your income information that you're already collecting in other areas of your health center, and that is now going to inform this policy. Previously, we had in the one before, it was 350% was what they had set it at. That was going to create a lot of challenges for the health center. Next piece that's new in these terms and conditions is they do set expectations for in the policies and procedures that we are going to incorporate new definitions for what do we define as that high cost sharing requirement, that high unmet deductible, or no healthcare insurance. And I will say I did feel like that was a bit of a thought exercise when I had to create a definition for no healthcare insurance because it felt pretty self-explanatory. But that is in the policy template that you all should have received. The last piece is the notice of award gives us expectations of when we'll be held accountable to this. Okay. And that is obviously top question on everybody's mind. And so we've been told that it's in Form 1C, the documents on file is where you're going to update information about your compliance with this. It's that they'll be able to check that at your service area competition applications or your budget period progress reports. We do also anticipate that you could have questions about this in your operational site visits. And so being prepared because HRSA can request those documents from you. And so you do need to be able to make them available for review. So we have gone through in detail the language that is in there. You are all now experts. And so just to hit a few highlights, this applies to three.
Felicity, can I add something there? I think something we ought to mention here is that this was put as a term and a condition on the notice of award. So I think that this is a really important place to put that it would be beneficial for every health center to have either a pharmacy or a 340B employee that has read-only access to the electronic handbook. There are three situations that really are important in the health center. That would be getting access to these notice of awards so you can read those terms and conditions, access to forms 5A, 5B, and 5C, which are important for 340B compliance and are required during a HRSA audit. And then the third one, if you have an entity-owned pharmacy, your pharmacy is going to be required to have the FTC deeming notice. So they can actually download that from the electronic handbook as well. So if you are interested in helping your 340B or pharmacy employee get set up on the EHB, we can help with that as well.
Yeah, and I 100% agree with you, Logan. They do not need right access, but having view access is so important for the people within your health center who are involved in the 340B program, particularly anybody who's listed as the primary contact, because they're doing the majority of the maintenance of the OPACE database and making all those changes, making sure that they're able to see what is in the electronic handbook so that they can keep everything up to date and accurate. All right, so we're going to jump in, just high level key pieces. The executive order applies to 330 grantees. So it does not apply to FQHC lookalikes, and it does not apply, according to the Bureau of Primary Healthcare, to health centers who are not participating in 340B. So you probably won't be on this call if that is you, but that is a distinction. And then the next piece is it's only for insulin and injectable epinephrines. It's not for all forms of epinephrine, and it's not for all diabetic medications. And then lastly, it is for individuals eligible for 340B. There's a few reasons for this. One, as I mentioned, that previous rule that was written by HHS for the last executive order, when they finalized that rule, it said that the previous executive order applied to health center patients. So again, federal agency making a rational interpretation of the executive order. The other piece that we have is that the executive order states that it needs to be consistent with applicable law. Okay, and one of the laws that we have to be consistent with is the 340B statute. 340B statute says we're not going to sell or otherwise transfer the 340B medications to individuals who are not patients of our covered entity. So even though the executive order does say individuals, we have within the executive order that it has to still be in compliance with law. And so to comply with the 340B statute, it is only patients of our entity who are eligible to receive those 340B medications. All right, Logan.
All right, shifting into our example policy and procedure. And this is only sections of it. We don't have the entire thing here. It is available in the handouts, or we can email you a copy. But starting off in our policy, we have that as a Section 330E grant recipient, the health center must comply with the terms and conditions. We've specifically called out the specific term number. Potentially this could change in the future. So you will want to look at that when you're reviewing your policy and procedure on whatever your review period looks like. And then with the purpose, the key here is that we want to highlight that we are going to ensure our compliance with these terms, but then we added that language there at the end that's in the bold, so long as it's in compliance with state and federal law and is not precluded or prohibited by applicable insurance contracts. We pulled this language directly from Chapter 9 of the Health Center Compliance Manual, the sliding fee schedule. It is a footnote there. Because there were some concerns that if we had insured patients who were under that 200% of federal poverty level and then fell into one of those two categories, they had a high cost sharing or high unmet deductible, that we may not be able to discount their copay or cost sharing requirement pursuant with the PBM contracts. Many of these PBM, pharmacy benefit manager contracts, preclude us from waiving or reducing the copay on the patient side. So we wanted to make sure we put that language in there to allow us flexibility if we did not feel like we were covered to do so. All right, and shifting to the policy definitions. As Felicity said, in the terms and conditions, it does require us to define certain terms. So we feel like even if you don't typically add policy definitions into your policy and procedure, it's very important to go ahead and put these here because it is specifically stated in the terms and conditions. So in high cost sharing, we define that as the out-of-pocket cost. So this could include coinsurance, copays, or another non-deductible cost sharing for a specific prescription of either insulin or injectable epinephrine that exceeds the sum of the discounted price of the medication plus the minimal administration fee associated with this policy. And where you see EIP, that is epinephrine insulin pricing. That's how we've defined it in the policy and procedure. High-end met deductible is very similar. This is the same as the high cost sharing, except this calculation is based on the unmet deductible. So it's still an amount that exceeds the sum of the discounted price plus the minimal administration fee.
And I'm going to pause you there for 1 second, Logan, because what I will say is that these are what we put forward in the template policy and procedure. I have seen other health centers who have chosen to set fixed numbers. The challenge with having a fixed number is that you may or may not know, particularly with the deductible, where an individual is sitting. Because with the out-of-pocket cost sharing, that will adjudicate back to you on the pharmacy side, but we may or may not get from the pharmacy system whether they have a high met deductible or not. It may be clear that they don't have, that they're having to pay out of pocket for the prescription, but we may not know how much is left in their deductible. And so setting it this way, we're making sure that our low-income patients are paying the lowest amount possible based on the discounts we would be offering or what their out-of-pocket cost would be. But you do have the opportunity, if you would like to adjust these. These are just ones that we have put forward as suggestions, but if you feel like this isn't the right fit, we're happy to talk through, what your thoughts are for something else. But we have seen people set, thresholds of high unmet deductibles or deductibles greater than $1,500, or a high cost sharing requirement is a cost sharing requirement greater than, say, $35, which we're seeing for insulin with Medicare, right? So there are some other ones that we're seeing floating around out there. But what we wanted to do was make sure that we created something that would have flexibility. And so this is where we landed to keep it open for everybody. But there are potentials that some health centers may want to use something different. So I just want to put that out there.
And knowing how a lot of you have your cash pay program set up, we felt like this was in line with what you were already doing. So it's going to minimize the changes that you have to make at your health center. So shifting to low-income individual, we put this in here, but this was clearly stated. We did not have to define this. The HHS or BIPIC did define this in the terms and conditions, being at or below 200% of the federal poverty guidelines. Minimal administration fee. This will need to be defined in your specific policy and procedure. This can include any dispensing costs, counseling costs, or any other charges associated with receiving the medication. What we would like to highlight is that one place, if you don't know where to start, would be looking at your Medicaid dispensing fee. Each state is required to do a cost of dispensing survey. Some states are better at doing it more frequently than others. And then create a professional dispensing fee based on that survey. What we're seeing, the national average is around $11.75. We're seeing lows in $8, almost $9. And then our highest is Oregon. Congrats. They recently changed theirs to $20.86. So our folks out in Oregon, well done. That is great. But it is appropriate for you to use that information to help guide your dispensing, your minimal administration fee. We'd also encourage you to actually use that term, not use a dispensing fee terminology, even though that's how we commonly talk about it. Because it could include other costs. So for example, when we're talking about a contract pharmacy application of this, we may have dispensing fees paid to the contract pharmacy, as well as fees paid to our third-party administrator, TPA. to administer the program. All of those are appropriate to include in a minimal administration fee, even if it exceeds what the state's dispensing fee is, because that is your minimum cost to actually provide the drug at that discounted cost to the patient. So you really have to look at your individual program to decide what that looks like. We're happy to help you in those discussions if you need it. And then defining no healthcare insurance. So we define this as an individual for a given period does not have any form of prescription coverage. So we thought it was important to highlight that that is specifically for prescription coverage, because there are circumstances, although rare at this stage, that patients will have access to medical coverage, but not prescription. So for example, a patient might have Medicare A and B, but not Medicare D. So that, I think, is an important step to take.
And just one piece to call out, the language in the no healthcare insurance, I believe many people, the version that we sent out originally said any form of healthcare coverage, and then subsequently we updated that to say prescription coverage. So the template that you may have received may say healthcare coverage, and we updated it this week to say prescription coverage. So that is a little bit of nuance.
All right. I think Felicity's, we both changed.
Yeah, so now we will jump into just talking about the procedure. And so, we've hit on some of these pieces already, but just getting into the eligible patients, this is just defining it in detail in the policy, but I'll just retouch on the fact that we have language in there that supports the federal requirements, and just documenting that we both are going to comply with the 200%, making sure that that the patient also meets one of those other three criteria: no insurance, high deductible remaining, or high cost sharing for that was up there as well. And then the last piece is just saying, in compliance with our federal requirements for 340B, that the individual also has to be a patient of the health center in line with the 340B statute and the 1996 patient definition. So just creating that additional coverage where the executive order lacked a little bit of specificity. We would have loved to have seen it say the word patient. It didn't. That's okay. And so we're just creating that additional language in our policy and procedure based on the legal piece that they gave us at the beginning.
And BIPIC was very clear that they intended flexibility. They specifically stated that in the webinar they had the same day that these terms released, that they intended flexibility to allow application across health center space.
The next piece is eligible drugs. The way that we drafted the PMPs is in line with BIPIC, right? And intended to be flexible across all of the health centers that we're working with. So when we say that you're maintaining a formulary of affordable insulin and injectable epinephrine products, that could be that you choose to do every single insulin and an epinephrine product that you're stocking in your entity-owned pharmacy, and you're just going to apply that 340B price plus the minimal dispensing fee to your patients who qualify for this. Or the formulary could mean that you're choosing to select a limited formulary of products, right? So that terminology gives you the flexibility to choose to go either way, either every single insulin and injectable epinephrine, or a small group of products that quarter are available at an affordable 340B price. We were looking at the prices today. We still don't have this quarter's updated pricing. We expect that within the next week, but based on last quarter's pricing, we did have a couple short-acting and a couple long-acting insulins that would be good choices if we were creating a formulary today. And then some products that are sitting in the hundreds of dollars, which even at the 340B price is not accessible to patients. So just keeping those types of things in mind, you can select elect to either do all or have those that are more affordable to your patients. And then as far as locations, similar. Again, Logan mentioned that the Bureau of Primary Healthcare has left it open to the health centers to define in their policies where access is going to be created. And so the key is that you're creating access. It's not a requirement that it has to be everywhere. And so the places that you may create access with maybe your entity-owned pharmacy. And if you have an entity-owned pharmacy, our guess is that is going to be the place that you choose to do this, right? You're going to have a lot more control in how you're able to implement it. You'll have more, that information about your patient's income level. And so
it's likely more affordable for the patient because we're controlling that.
Yeah, it's going to be a lot more readily accessible, and you can also just do a lot more intervention with your patients, and so chances are that's where you're going to choose to apply it. If you only have contract pharmacies, you do actually have a couple choices. One is what you're already thinking about, right? How do I apply this at my contract pharmacy? But the second is you could also choose to do a provider dispense. That does need to be in compliance with your state laws, right? And so making sure you think about that. But it may be that if you are not able to figure out how to do this through your contract pharmacy, that you may choose to have a small formulary of medications that you're creating access to through your health center, through physician dispensing. And if that is the right option for you, please contact us and we will work through that with you. That is an adventure that I think few will choose, but let us help you with that if that is the pathway that you go down. All right, and then last couple pieces. Again, because we are none of us psychic, we will, within the policy we wrote that we will be adjudicating, and this ties into our expectation as health centers to maximize our billing opportunities with our payer contracts. So we'll adjudicate the prescription to understand where the low-income individual sits within their high cost sharing or high deductible requirements. And then, as Logan mentioned, if for some reason there is something to do with that specific plan where you feel like it's precluded under your contract, then that's a different determination. But initially to identify if the patient is even eligible, you will be billing the insurance to identify, and if you decide that you cannot at that point slide the copay or reduce to this reduced pricing, then you may decide that you have to do a reversal and bill differently. But what we're seeing across the space is that we're working with NAC to raise questions to the Bureau of Primary Healthcare, because as 330 grantees, we do have a federal obligation to make sure our patients have access to care regardless of their ability to pay. And that is a federal law. So we're trying to understand how that federal law plus this executive order meets with our PBM contracts and the PBM contracts stating unless we're required by law. And so that's something that we don't have full insight to, but we're working closely with NAC to explore, and hopefully in the coming months may have some more information on that. That's more of a sticky situation. The last part, and this is language that came out of the previous executive order rule, but also just is based on the literal language of this executive order where we have to provide the discount to the individual. But the previous rule stated that the health centers are not required to charge the third-party payers the discounted price. Okay, so we are required to give that discounted price to the individual, to our patients, but we are not required to give the discounted price to a commercial insurer. So very important to note that. And from there, Michael takes the stage.
All right, so time to go over some frequently asked questions. We went over a couple previously. Where is that? There we go. I'm new to this, guy, so hang in with me. I'm All right. So first question we have coming up, Felicity and Logan. When must health centers comply with the new 330 grant terms and conditions?
I'll go ahead and take the start at this. So as the terms and conditions stated, it has to be included definitely by your next service area competition or SAC, or your budget period reporting. That is what's required. But we also, because this is conditioned on, our 340 grant is conditioned on these terms and conditions, we also feel like the operational site visit is probably the most likely place that you will find out about it, that you'll be asked to provide these policies and procedures. It will definitely go in that SAC Form 1C, but those other two places are possible. So there's no definite timeline, but what we're saying is go ahead and get these administrative tasks done now. That way you don't have to look forward to it. And what we're also hearing from BIPIC is some good news for us, that our SACs are extending to 4 years. That will be slowly rolled out. It's not all at once. So we will have longer periods of time between OSBs and SACs.
Hey, we're all happy about that.
Yeah, all right, we'll go on to the next question.
Mm-hmm.
All right, so here are some formulary considerations. What products must health centers include to comply with the new 330 grant terms and conditions?
Yeah, and I feel like we've hit this one a few times already, but just to reiterate one more time, you could choose to do all insulin and injectable epinephrine products and offer those at the discounted price at your 340B price plus your minimal dispensing fee, or you may choose to have a set formulary. One of my goals is that once we do see the new pricing for the quarter, that our team is going to work on creating maybe a suggestion of, here's what might make a reasonable formulary for all of you to consider, and that we would share that with everybody once that's out. But we're not able to produce that for today because currently there are only 3 manufacturers of insulin who have their pricing into the price file so far for the quarter. So we could not get you that information.
And what we've seen in the webinars we've had for NAC and different things is that commonly GLP-1s or glucagon-like peptides, so Ozempic, Trulicity, Wegovy, Mounjaro, a lot of times because those are injectables that are used for diabetes, people think that they're insulins, and that is a misnomer. They are not insulins, so they are not included in this. Also, there are other forms now of epinephrine. While I think it's great, we now have a nasal form of epinephrine. It will not be included in this, which is probably okay because I'm going to guess it doesn't have a great 340B price yet. It would still not be accessible to the patients because it's so new.
Next question. Who is eligible to receive access to discounts under the 330 grant terms and conditions? Is it all individuals?
So reiterating what Felicity said about this, it is reasonable for us to limit this to only health center patients. Someone can walk off the street and may meet these qualifications, but they're not eligible to receive 340B drugs. So it is reasonable for us to say that we cannot comply with that. Now, what I will say is that's a great opportunity to talk to those patients and let them know about the ways the health center can help them. And maybe they can be established as a health center patient, then they would be eligible, but it is reasonable to not extend it beyond 340B eligibility.
Also a great time to encourage people to become patients of the health center.
And I think something else here that's came up is who has to determine the eligibility? We've had questions from people saying, if someone comes up to my pharmacy counter and they haven't given income information to our front desk and qualified, do we have to extend the price? And we would say that that's not required. You can reference back to your sliding fee discount policy to define what those processes look like for the patient to become eligible for the sliding fee, which then will feed into how we determine who is eligible for this low income status.
Yeah, we definitely encourage you to use the income verification processes you already have in place, and then apply that. And it may be that when somebody presents at the pharmacy and is asking for this, that they have to be directed to the people who are doing that process. You may also want to have the forms available at the pharmacy if you have entity-owned pharmacies and you're finding you're getting these types of requests as a pathway that they can start filling out that paperwork and have directions for where they're to return that to. But there is not an expectation, because there is an income verification level, for you to extend this pricing without having conducted that.
And how awesome is it that got modified from the first time that it was passed, right? Because it was at 350% poverty level. So then we have to recalculate everything for all of our patients. So that was a definitely beneficial change. The next question here: must health centers provide access to discounted pricing at all of their pharmacies, entity-owned and contract?
No, and we've definitely hit this one as well. You must provide access. You must have a plan of how that access is going to be provided. You can choose to provide it everywhere, and some people may, but our guess is that you may have an easier time and a harder time applying these discounts at some of the contract pharmacies, and so based on where you're able to create the access, that will be what you do. Your goal obviously is to be creating as much access as possible, but you also need to be operating in the realm of possibility. And so sometimes that is it's not possible to offer these discounts at every single contract pharmacy, and that's okay. The key is creating access points, and then making sure that you share this information with your patients as you have the access created.
And I would foresee that most of our clients that have entity-owned pharmacy, that's where you're going to actually provide this access, because as we said, it's the easiest application. We have access to the electronic medical record, so we can see that income determination, and we can provide that the most affordably for the patient in most cases. But you may also, in your entity-owned pharmacies, may not be at every site. So think about ways that you can provide that access from that location to your patients that might not go to that pharmacy physically. So that might be delivery, delivering to clinics for pickup if allowed by state law. Definitely check state law. We can help with that if there's any questions on that. But you can really extend that access without having to open your contract pharmacy cash programs. I think you went to Michael.
No, I took it back. I took it back because he and I both clicked it.
Okay. So next question: when can health centers discount? Oh, apparently I messed up today. When can health centers discount patient cost sharing?
Rock, paper, scissors. I'll start. And so within the handouts that we've shared, we've given a couple different references. Starting with the Medicare reference, which talks about health centers, FQHCs, being able to discount or the copays for Medicare patients. Additionally, and it is copays, it does not reference deductibles. But additionally, there is language from the Bureau of Primary Health Care's Health Center Manual from both Chapter 9 and Chapter 16 that talks about applying the slide to copays, and as long as you're not prohibited by your contracts, and having a discussion about how that works. And so if somebody has insurance and the copay is higher than what their charge would have been, whether it was slide or now on this new insulin and EpiPen pricing, then you are it has the explanation of taking that copay down to what they would have paid if they've been in an uninsured status. So still billing the insurance as long as not precluded, and then reducing that cost. Logan, other pieces to say to that?
I think the key is here is that you have to have a conversation. Leadership and pharmacy teams need to put their heads together and decide what they are willing to do, what they feel comfortable doing. That may mean you have to pull in some legal counsel to see what you feel comfortable with doing. Look at your PBM contracts, see what they specifically say and what flexibilities you have there.
Yeah, and again, it's we got a question from Kristen in the chat, sort of like about more detail on that, right? And so really encourage you to take a look at the handout that we gave you that has it's the one that's titled the Insulin and Epi Resource Sheet. And so it goes through the key language from each of those documents that you need to know about sliding those copays within the health centers. And so this is probably the hardest part, is interpreting what is required by law, right? And then what is prohibited by your insurance contract. And so some of this is up to your interpretation and legal counsel's interpretation. It may also be, you know, working with the pharmacy benefit manager to have conversation with them about your interpretation if you want to take that strategy as well. But again, as stated, right, that your 330 grant and the 330 statute does have expectations of us creating access for our for everybody, first of all, but especially for our low income individuals. And now we have this additional mandate to create that access. And so you know, how does that meet with the pharmacy benefit manager contracts that say you can't waive unless you're required by law? And there are definitely, you know, we are not lawyers. We are not lawyers. We are not close to lawyers. But you know, we've definitely heard some who interpret that as being the legal requirement. But this would be where we would encourage legal counsel to be involved in these types of considerations. Or, you know, and just making those determinations. Or if you're not comfortable with that, then that's where we have the language in the policy and procedure that says unless prohibited by your contracts, in which case then you're interpreting that you can't extend that pricing, right? So there's nothing in this executive order or the terms and conditions that is attempting to compel you to do something that you believe is illegal. Okay, that's the key here, right? You both in the executive order and the terms and conditions, there is an expectation that you are complying with law. And so if and in your BIPIC manual, there's an expectation that you're complying with your contract. So if you believe that something would require you to be out of compliance with either of those things, then you would not be able to extend that discount. And that's okay, right? That's an okay decision to make. And that's how we've crafted the policy to create that protection for you. And so then then you're making different decisions about how are you handling the patient and how are you handling the charges. Okay. Admin fees.
The next question about the admin fee. So how should a health center define a minimal administrative fee?
And we talked about this earlier, but I think you really need to look at your specific situation. If you have an entity-owned pharmacy, you may already have this defined. It may already be set up in your whatever cash discount program you have set up in your pharmacy. So it may not be recreating the wheel, but then when we get into contract pharmacy, really think about those extra fees that are associated with providing that discount. And this is not defined. You are allowed to define this. This is appropriate. But if you need somewhere to start, look at Medicaid dispensing fees. Those are pretty easy to obtain. You can often get a whole list of them right on the Apexis website. They have a Medicaid tool that you can look up your state and see what your dispensing fee is. So that is a great place to start.
And it is linked in the chat. All right. As far as, we're back in the survey questions. So now we're going to test your knowledge one more time, and I expect 100% from everybody because you all have done such a great job of listening. So true or false, health centers are required to offer reduced pricing at all contract and entity-owned pharmacies. And we've got false, A+, everybody. We are giving the answers this time.
All right, true or false, the access to discounted 340B medications must be given to all low-income individuals who present at your pharmacies. All right, we got some early adopters answering, and it looks like everyone's getting the right answer. This is false. This is only required to be given to our low-income individuals who are patients of the health center and who also have a high unmet deductible, high cost sharing, or no insurance.
Yes, perfect. And then last one is the executive order requires FQHCs to provide 340B pricing on all diabetic medications. And again, A+, everybody. So 100%. Whoop, whoop. So that is also false. No insulin and injectable epinephrines. And even then, it's not all of them. You can choose to have a formulary of what would be affordable for your patients. So we're going to jump into questions. I know there's one more in the chat that we have not hit yet. And so we'll take a quick peek at that.
Okay, here's one. If a patient's over 200% of the federal poverty level but has a high deductible plan, they do not qualify for the discount. Is that correct?
So under the executive order, they do not apply. They do not qualify for the executive order mandated discount. However, in Chapter 16 of the Health Center Manual, because prescriptions are supplies, we are not services, we are allowed to set up discounts for our prescriptions that are not tied to 200%. We can choose to offer different discounting on our prescriptions. And so again, thinking about that requirement to create access because of the ability to pay. And so again, that reference that we've given you to go to Chapter 16, take a look at it. You have the option from Chapter 16 to do flat fees, to do sliding fee scale, to do at cost for your prescriptions. It's up to the health center to set a standard. That chapter is not based on an income level specifically. Most health centers do choose to apply it as a slide and use that 200% threshold, but that's not a mandate within Chapter 16. So,
and also within the Medicare Safe Harbor that's linked in the resource guide, that also. That chapter also hits RHCs, rural health clinics. They specifically have to assess income level, but the sentence about FQHCs that precedes that does not discuss income levels, that we can provide it when a patient expresses an inability to pay.
So there's one more question in the chat. I don't think we went over yet from Lisa.
Yeah,
if we have a current pharmacy, does the insulin fee need to be equal to our pharmacy's dispense or our pharmacy sliding fee? Their sliding fee is acquisition cost plus a fee, which increases per slide level. And as all patients are eligible for EIP, would also be eligible for their sliding fee. Do we need to distinguish those in our record?
Yeah. So I think this is an interesting question, right? As to what is the minimal dispensing fee that you set. And I think that we can do more than minimal dispensing fee, as in like charge less. but but I think that's an interesting question. And so part of the reason that we suggest calling it an administration fee is that you do not have to tier it. But that isn't to say that the tier levels that you have in your slide do not make it more accessible. I think that it's reasonable for you to use your slide, and you're doing actual acquisition cost. I would suggest that you I think it's a little bit tricky with that administration fee, right? Where you're going to have different levels, and where it has that language about minimal. So what we're going to do, we'll take that one to BIPIC and get them to weigh in.
My opinion on that, Felicity, is I don't see us getting in trouble for undercharging the patient. And so if the slide, let's say there's slide A, and we put the EIP at the slide D level, right, which is the right under 200%. I don't see a world in which we are not allowed to give them the slide A that they qualify that is lesser than the EIP. So I don't necessarily know that we'd have to worry about that. And I
agree.
What do you think?
I agree. I feel like as long as your top of your 200% level, and that first level of your slide is what you define as your minimal, and you go down from there, I think you're okay. But what we will take it to BIPIC just because that is one we haven't got before. And so
we're seeing very few pharmacies these days have a tiered dispensing fee, because they're following under the Chapter 16 definition instead of the Chapter 9.
Yeah, but we will take it. If you call it a dispensing fee, you have to. They want you to slide it. If you call it an administration fee, you don't have to slide it, which is part of the reason why they termed this one administration fee. Yeah. And so, but we'll just double check on it. But I do agree with you, Michael. I don't see any reason why it should, as long as you set the top tier in line with what you're saying is minimal. Okay. Because if your bottom one was what you called your minimal, then you would be overcharging everybody above that bottom level of your slide. So I think you have to, in your policy, define minimal as whatever your top slide number is for your 200 to whether it's 200 to 150 or whatever your top tier slide is. And then after that, I think you're okay. But just make sure you have the bottom level. Like if your bottom level pays $3 as their admin fee, don't call that your minimal administration fee and charge the top of your slide $5, because then you're overcharging the top.
And if we align, because I think in most cases the EIP is going to be aligned with the D slide, right? Probably the last slide on the list. And so if that is aligned, then essentially you don't even need to build anything out in your pharmacy system. You would just charge your sliding fee, right? That would just hit either slide A, B, C, or D, and you wouldn't have a separate annotation for this EIP program because you are meeting the requirements by charging them the minimal fee or less. Do you agree with that?
Yes. And so I'm going to address a couple questions from the chat. Yep. One is asking about the Ozempic Mounjaro. That was us clarifying that the GLP-1s, or the very sensational weight loss drugs that are all over the news, those are not insulin products. Those are not involved in this executive order mandate. They're not included. We do not need to create this access discounted pricing for those medications. The other question that was in the chat was just about admin fee and dispense fee. So interesting, right? Again, I'm going to go back to that regulation, or so that rule that was published aligned with the 2020. There was a reference in that previous rule about dispensing fees and needing to slide dispensing fees, and they actually referenced back to the health center manual and said that chapter 9 said that we had to slide dispensing fees. There is no reference in chapter 9 to sliding dispensing fees. However, we do hear this on operational site visits all the time because they are considering the dispensing to be a professional service. So if you are defining something as a dispensing fee, it is not infrequent that in an operational site visit, somebody will ask you about your slide for your dispensing fee, not about any other part of your cost of your drug, but just about that dispensing fee that you are charging. If it is referred to it as an administration fee, that is considered like admin and not sort of how we typically think of like administering, right? Like giving an injection. Think of this as like your administration overhead. And those are not considered to be service. It is considered your cost of delivering the drug, not a service. And so there's not an expectation for slide there. So that's where that nuance comes in. So when it's an admin fee, it can be flat. If it's a dispense fee, it's a service. It has to be, there has to be a slide that's applied. So it's kind of a nuance there, but if you do call it a dispense fee, then expect the operational site visits to want to see those tiers. It's all a lot of fun. We will be here for you. If you've got more questions, we're happy to do one-on-one sessions to get into the weeds with you on your specifics, to talk through your very specific scenarios. But what we wanted to do was get here today with you, get you all up to speed on what is going on, what you need to know, what's in that PMP that we sent out. And then from there, we can get together and connect and talk about what you need to do within your organization specifically. And we've got some suggestions for other topics coming in the chat, but please, if you've got other things that you would like us to talk about, let us know. And clinic administered drugs, we've got just the right person on our team to talk about that. So we will definitely put that on our list to come back to you. So I hope everybody has a wonderful rest of your day. Thank you for joining us. You all will get this recording. And if you were not able to download the handouts, because I did see one person was mobile, please just let us know and we will send those right out to you. All right. Thanks, everybody.
Thank you all.